Endodontic treatment is a delicate process that happens inside a tiny space in the human body. So perhaps it shouldn't surprise us that despite everyone's best efforts, sometimes challenges and complications arise. What happens then? Does the tooth always have to be removed, or is there hope to save it with the right people, skills, techniques and instruments? I'm Peter Norton. Welcome to this first episode of Gentle Endodontics TV. We're joined by a panel of experts who are here to assure us that perhaps all is not lost, even when a tooth experiences some difficulties. It's a pleasure to share the desk with Adjunct Associate Professor Mehdi Rahimi, Dr. Paul Nakad, Dr. Muna Al-Ali and Dr. Mark Johnston. Thanks for being with us.
Thank you for having us.
Our studio is on traditional Cameragal land in northern Sydney, and we pay our respects to elders past and present. This discussion is interactive, so please send us your comments and questions. Your questions are anonymous, and we'll get to as many as we can in our time together. Mehdi, without sounding too negative, when it comes to endodontic treatment, there is quite a large range of potential complications, and for us to discuss all of them is going to take all night. So what are the main endodontic complications that we're going to be focusing on this evening?
The clinician, when it happens, is what we're going to cover. So we'll cover perforations, sodium hypochlorite accidents, altered sensation, and fractured instruments.
Are we looking at the prevention, management, and prognosis of those scenarios?
Correct. We'll try to cover that.
Great. Well, Paul, then can you maybe start us off by talking us through how we can minimise the risk of perforations during endo treatment?
Yeah, of course. I think the general take-home message tonight is going to be prevention is key. So when it comes to perforations, what's very important and what I like to put forward to my cases is having a very good preoperative assessment. And it might just start with a simple radiograph. So you can see in the case we got here, there's a lower molar, it's got an indirect restoration, and it's mesially tilted. So to the naked eye, what we're seeing is that you've got this bridge that's trying to compensate for the mesial tilt. And if we don't pick that up with the radiograph, we're going to want to follow what we think is the long axis of the tooth, and we're going to go out the mesial and risk perforation here. This is where having good imaging and having good radiographs are going to allow us to follow what really is the long axis of the tooth. So we try and prevent perforations. And then in a situation, we're going to be able to pick up that there's calcified canals here. So even though we have our routine periapical radiographs, I think having 3D imaging is going to give us a lot more information as well in these situations.
And as you can see in this case in front of you, the CBCT was very important because obviously the canal system was calcified when the case was referred. Most commonly what we see as dentists refer is due to the inclination of the teeth in the anterior region, most dentists will go towards the buccal. So as you can see, that axis was far towards the buccal. And similarly in the lower dentition, I see the opposite often because of the curve of Wilson, especially lower premolar region. We can tend to go towards the lingual because of the inclination of that crown. So obviously, I often teach, wherever I teach, especially with students, to have your burr more aligned with the palatal and in line with the palatal area. And it's better to always look at the crown and the root. So sometimes it's good to have a split dam to know exactly how to align your burr.
Okay, well, I think we'll be looking at split dam later on. Muna, there's a variety of perforations that can happen. Can you talk us through what a strip perforation is?
So a strip perforation is a perforation that happens in the danger zone, as we like to call it, in multi-rooted teeth. It is the area where the root is the thinnest and it's at the furcation side. And usually it happens because of preparation in that area. I'm not saying over preparation because the teeth originally start with a very thin dentin there. So a minor preparation in our eyes might be over preparation for that thin dentin there. So it can happen with any tapered rotary files. It can happen even with manual instrumentation. Can happen with post-preparation gate splitting or post drills or any instruments that you can use. It's just because of that little concavity or let's just say thin dentin in that area.
And Mark, there are certain teeth and certain roots of certain teeth that are particularly prone.
Yeah, well, especially like with the image beforehand, we've got the mesial roots of lower molars. Those in particular can be quite thin in that cervical portion. So if you're using instrumentation systems with very large tapes, you've got to be careful as you get to the larger sizes because they're going to remove quite a bit of tissue from that coronal part of it. But then you've got the other teeth that are very common, like your buccal of an upper premolar, for example. And here's some examples here where even in a single rooted tooth, you can have a little bit of a concavity on the mesial aspect. In multi-rooted teeth, on the buccal root especially, you've got that little furcation concavity. So you want to be careful you don't over-instrument these canals. But this is also why, if we are placing posts, we want to avoid doing them in these danger zone teeth, especially like the buccal of an upper premolar. We like to keep those posts in the palatal because we can end up perforating them. And there are some tips and tricks if you are using posts, for example, which we can cover in a moment. But the other thing that we need to keep in mind is, thankfully nowadays with heat-treated file systems, we can keep them rather conservative in that coronal portion while still instrumenting the apical part to a satisfactory degree. And Gates Gliddens historically were used to open the orifices of teeth, but I think a lot of us have come away from that sort of technical process of instrumenting root canal systems. You can use heat-treated file systems to open up that orifice area and still maintain a nice thickness of dentine to do the rest of your treatment.
Well, Muna, sometimes perforations happen during the preparation of a post hole within a tooth. Do you have any tips that we can sort of follow to help to reduce those incidents?
Well, the best tip that I can give is just follow the inclination of the tooth as much as you can. And what I personally like to do is just remove the GP with heat systems like System B, whatever you want to like use. And that will kind of like give you a direction or a feel of where the post space is if you needed to enlarge it with other instruments like a pulse drills or something like that. So you don't have to, go off track or pressure too much when you're just enlarging a space that is already there.
And Mark, you've had some success using special rubber dam clamps, is that right?
Yep, so personally, when I'm accessing teeth in general, this isn't really related to the post specifically, but just in terms of access cavities, I really like using the acrylic clamps for calcified molars, because if you're doing an access and you want to get an idea of where you are in space and you need to take a mid-treatment film, if you're using a regular metallic rubber dam clamp, taking a film is going to be completely obscured. So if using one of these acrylic clamps, for example, it shows up as a grey ghost image on the radiograph, and you can get a much better gauge of where you are in 2 dimensions to determine whether you're going to possibly perforate interproximally or in the furcation itself. And the ghost image itself is very easy to see through with these clamps. The only thing I've found over time is that the clamps themselves can lose quite a bit of elasticity through overuse, so that there's something that you need to keep an eye on as compared with the metal clamps. But these work quite nicely, and especially in crowned teeth as well, where you've got the obstruction of the crown plus the obstruction of a clamp. You can't see anything till you're into the roots. Not only does this clamp not cause a lot of damage to the crown itself because it is acrylic, it'll also help you once you do get past that margin of the metallic crown and get into the pulp chamber itself on the film.
You can also use multiple isolation if you clamp a little bit further away. That will clear the space for you.
Yeah, definitely clamping distal and then using a cuff technique or multi-tooth isolation is also a really good idea.
Multi-isolation.
Well, Mehdi, I think this is your case where you've done just that. Can you talk us through it?
Correct. So initially I went into this case, and as you can see, we did the isolation further away. So you can see the clamp on that upper right premolar, and we moved the clamp to, it might have been upper right canine, and we moved the clamp to the tooth of interest, which is 21. And I went in helping out one of my colleagues, and as I said from the beginning, often dentists go buccal, so I went too far palatal and perforated on the palatal side of this poor tooth. So as a result, whenever this happens, especially in our clinic, then the person who perforates takes on the case and manages the rest of the case. So I take on this case, and I do. We do place the temporary, a well-sealing temporary with some calcium hydroxide, and that really helps. It's like the calcium hydroxide is acting like a radiopaque material or a radiographic tracer. The second CBCT, which I really think is one of the most important CBCTs when you're dealing with calcified canals where you're struggling to find them, is to take it to know exactly where you are. As you can see in that lower image, that axial slice, we were slightly more palatal and more centered, and slightly more buccal was where the canal was. And as you can see from the next slide, here the red arrow points to the actual canal, and where we'd gone was more palatable. So at the time when the perforation occurred, we recommend, if you don't have time, and you're obviously sometimes stressed, please disinfect the perforation site with sodium hypochlorite. You're not placing hypochlorite under pressure or under back pressure. You're just disinfecting or bathing it to disinfect it. And the best is to seal with a cavet, because cavet still can seal, and you can do a double seal over top of that with GIC, and then we take on the case. So we don't like those whopping huge cotton pallets, because they will just leak and the temporaries can break down, and then the perforation becomes more established bacterial biofilm type thing. So here we located the canal, and the way I sealed it, if we have a look at a quick video clip here, is I placed a paper point, so that's the master paper point, size 40, in the main canal, and I'm sealing the perforation because it's quite a fair distance from where the canal is, so it's not going to impede my way to then manage the case. And one of the other reasons why I sealed it, because I knew I'm going to wait a little while. With perforations, I prefer to see the patient again. Like many complications, I prefer to see them to make sure they're okay, because obviously a complication did occur. Prefer to make sure they are asymptomatic and I'm seeing evidence of healing prior to obturation. So that's just my personal preference. So here we place MTA. It's a dry mix. We're using long pluggers, or Schilder pluggers, sometimes they call it, or Buchanan pluggers. And I'm using the MAP system, an MTA carrier system. And I'm quite generous with this dry mix of MTA, almost like packing amalgam. I guess that's how we're packing it. And then I go with the next video, which is because MTA takes 3-4 hours to set, then obviously I don't want to contaminate it with moisture. Therefore, what we do here is we protect the MTA with glass ionomer, and notice how the long tip on that Riva or Fuji helps us get deeper within that pulp chamber. And then when the GIC is tack set, is when I carefully wiggle out the paper point.
And is there any concern in your mind that the paper point will become adhered to any of the materials you've used?
Occasionally it can, but that's why you just got to be sort of at the right timing, carefully removing the paper point. If you're really worried, you can coat it with a bit of Vaseline.
Would you ever consider using a Master GP cone instead?
And a Master GP certainly is a good option as well. Certainly, I think in this case, I'm not sure I use the paper point, but yeah, definitely a Master GP is also a very good option.
And Myrna, you were saying something?
Oh, you can rotate it while you're waiting for the set. Just keep rotating.
Yeah, it's just as long as it doesn't stick to it, it's fine.
Yeah.
Now, thank you for your questions. We will get to as many as we can. If you're watching us on Facebook Live, welcome. It's really great to have you with us. Just bear in mind, we're not monitoring any questions you might leave on Facebook. So if you'd like to contribute to the discussion, if you'd like to ask a question or make a comment, please head over to the URL that's on your screen now, and you can submit your comments and questions there. A question from the audience, Mehdi, do you prepare perforation sites mechanically, for example, with ultrasonic, if there are signs of periradicular radiolucency?
Depends on how old the perforation is. So if the perforation's old, established, I do refine that area of the perforation. So sometimes I might use a long, they used to call it pulper, but I prefer the, I like endotracers or the Munspers, or I might use ultrasonics, and I might just clean out that perforation site. So trying to get rid of the affected, potentially infected dentine, because obviously it's established biofilm.
All right. And why do you keep the MTA dry for perforation repair? It's
just very easy then to compact it. And if anyone wants to learn about MTA and use of it, because I still fully use it in clinic, then go to advanced courses. People run advanced courses around.
One thing I'll mention about that, when it comes to the MTA, if you place it, if someone is using it, for example, and it is a little bit too wet when they've placed it, rather than having to worry, it's going to wash out or I've got to dig it out, you can just pat dry it with a sterile paper point as well, and that actually wicks up the excess moisture and dries it up at the site of the perforation. So worst case scenario, if it's a little bit too wet when it goes in, as sometimes it is, you can just spot dry it at the same time.
And then prior to placing MTA for perforation repair, would you use dentine conditioner in anticipation that you're then going to be placing a glass ionomer over the MTA?
Yeah, it has been recommended. The only problem with dentin conditioner is it's a liquid form, and I sort of don't know how far into that MTA it goes. I love MTA. I want to make sure MTA does what it does, which is to set and release calcium ions and create an alkaline environment. So it's possible that when you do dentin condition, if it does sort of it's within the MTA, or if you use a lot of it and you're a bit sloppy, it can actually potentially affect the setting reaction.
And before we move on, Mehdi, with regard to this case you mentioned the patient being asymptomatic and showing evidence of healing. Can you define evidence of healing?
Well, radiographic, and often these days we'll take another cone beam CT. We're not worried like we used to be about radiation safety and things, because obviously we know it's very low, and there's enough literature now coming out of Harvard to suggest that we can take it. So prefer to take a CBCT because it shows us you can actually measure how much healing you've had in that 3-month period or so that you've been watching the case. So not everybody does it this way. You can do it in one visit, but I prefer to, in complication cases, see the patient again. It's about patient management more than anything else. I want to make sure, yes, there was a perforation, but the patient's asymptomatic when they return to the dentist for the restoration.
Sounds good. Paul, there's a range of materials available for perforation repair. What can you tell us about them?
Well, look, I think a lot of it can be operator preference, but kind of my general rule of thumb or my philosophy is very location dependent, depending on where this perforation is going to be. Is it going to be below the crestal bone, or is it going to be above the crestal bone? And that's really going to dictate whether or not I'm in a closed system or whether I'm in a system that's actually open to periodontal fluids, tissues, and whatnot. If it's a closed system and I'm looking at a perforation beneath the crestal bone, I want something biocompatible down there. And MTA is a really good material to use. Now, the issues with MTA is that it does stain. So sometimes in anterior teeth, it may be contraindicated. So that's where something like Biodentine, which is on the market now, doesn't stain as much as MTA. So that could potentially be a material of choice. When we start to look in our open system, so things that are above the crestal bone, MTA can wash out, so it's not going to have the time to actually set. That's when you probably want something that's a bit more biocompatible. And we've got Jerry Store on the market here, which is a resin modified glass ionomer cement. That's something that's not going to be able to wash out. You're going to be able to control its set as well because it's a dual cure. And that's when I'll start to use those type of materials when they're sitting above the crestal bone.
At what depth would you worry about discoloration due to MTA when you're using it on an anterior tooth?
Look, I think you sort of need to worry. You should always have it in the back of your mind. Now, if we're going significantly below the crestal bone and that MTA isn't packed up high towards the coronal portions of our canal, then we shouldn't worry. But if we're starting to see it at the crestal level and at the orifice, then it's very likely that it can stain.
Well, Myrna, you have a case as well to share on perforation repair.
Yeah. So this gentleman is actually a colleague. He had root canal treatment done by another colleague, but unfortunately when they were trying to create a post space, they perforated. And according, as you can see on the first radiograph on your left-hand side, you can see that the perforation is almost crystal level. I would say a combination between crystal, subcrystal, and supracrystal, as you can see after I open up the flap. Now, looking at the amount of damage and looking at the position of this perforation, it was pretty hard to just seal it from an internal approach. So I decided to just lift up a small envelope flap for surgical approach and just sealed it up with a light cure resin modified GIC or glass ionomer filling, and I put it back on. This is another case where a colleague of mine, an endodontist, who thought that there is a middle mesial, and unfortunately it was a little perforation in that focal side of the mesial root, and extruded the GP in massive amount, obviously, through that. Looking at the structural strength of the tooth, it just didn't seem to me as a good idea to go back into the tooth and clean it out. And looking at the amount of the or the extent of the material that was extended, plus the history of the patients just having little periodontal abscesses next to the tooth, so it's more crystal levels. So I decided, again, another surgical procedure where I removed that excess material and placed a little bit of MTA in that perforation, as you can see. Unfortunately, it was too small that I can't get it on the radiographs. But as you can see, everything went nicely and it healed. And this review is, as far as I remember, is about 2 years after.
A question that's related to that, if we were to cause, for example, a 2mm perforation in the furcation region of a molar tooth, could we use glass ionomer only if we don't have access to MTA, or even composite if we could get good isolation?
Well, as Paul said, the choice of material will be dictated by the position of the perforation, and this perforation is considered crystal level, and we are in contact with bone, and you really don't want to have that GIC in contact with the bone. It's not as good to the bone as the MTA or biocompatible or bioinductive. There's also the issue of moisture control there, and it might not adapt well to the margins, so your marginal seal is not as good with GIC. So it's preferable to have MTA if possible.
And in the case
In
the case you just showed, would you ever consider placing a post in that case?
Which one?
The one that's on
premolar?
the screen. No,
I would not know how much of the tooth is under that crown.
Let's then ask as well about the premolar, because that might be
that
what
premolar, I actually discussed that with the referring or the colleague himself, because he's a dentist as well, and I prefer to have a kind of like an overlay or onlay direct type of restoration rather than a crown, to reduce the amount of tooth structural loss, because they were preparing a post because there's not much of the tooth left except for what you can see. So.
And Paul, what are the chances of success when perforations happen and are then repaired?
Yeah, I think when we talk about prognosis of perforations, we go back to one of our landmark papers by Fuss and Trope, and the 3 prognostic factors that they ended up talking about in their paper was location, size, and time. So with location, we discussed slightly, those that are in a closed system, so beneath the crestal bone, tend to have a better success rate because they don't have much communication with our periodontal tissues. Size, the larger the perforation, the harder it's going to be to seal, and time. So if there's mature bacterial biofilm there, it's going to be harder to disinfect. So those were the 3 that Fuss and Trope brought out. When we start to look at some of our contemporary literature, they contest that slightly, and that's going back to the materials that Fuss and Trope had back in those days, and it was mainly amalgam and super EBA, which weren't as biocompatible to tissues. So when we look at materials like MTA now and we study them over long periods of time, we don't think that those 3 are as important, more so the time and the size. Maybe location is now our prognostic factor. We need to also consider things quite logically. So where we are now is if there is a periodontal probing defect associated with the perforation, that is a strong prognostic factor, because now that's communication. It's communication for bacteria to go in through the periodontal tissues. And then also thinking about it logically, the structural integrity needs to be considered. So even though size may not be a factor for the perforation, if we've taken out a significant amount of tooth structure, the longevity of this tooth and the likelihood for it to crack is then going to be a factor that we need to consider. So that's sort of where we are now with perforations.
All right. Well, Mehdi, no pun intended, but the next endodontic complication, which can incidentally flow on from perforations, would be a hypochlorite accident. So what can you tell us about them?
So hypochlorite accidents obviously are very stressful occurrence, because often patients will let you know it occurred, and obviously it creates a panic. So it's actually very important that you hold yourself together, because obviously patients can feel that if this occurs, and be confident and calm with the management of it. Unfortunately, this particular hypochlorite incident, which is a lower premolar area, the dentist obviously, despite most going towards the lingual, has not been able to locate the canal, has gone buccal. They didn't really notice that they've gone buccally, and they've then gone in to clean out what's appeared to be a canal, and it was actually a ecocrestal or subcrestal perforation. So the hypochlorite's gone right into the tissues. When I saw the patient, this is the type of patient where it is best that they are referred, and they are also referred to even the oral surgeons, because what we see there is actually soft tissue that's been dissoluted away, and there's actually bone, necrotic type bone, and I didn't go chasing or touching, but I could even see the mental nerve.
Because even though this photo almost looks like a maxillary photo, it's
unfortunately a lower premolar. So this is one of those areas where extra care is taken, especially if you even going through, for example, the case that we saw at the beginning with Paul was discussing. If you're going through bridge work, it is possible you could go buccal. And if you're going through restorations that are quite broken down, teeth that don't have the original anatomy, they're worn, it is possible to go buccal. Even under the microscope, you can go buccal.
Prepared teeth as well.
Yeah, so I think this is where, it comes down to avoiding it. Prevention's much better than then having a patient with paresthesia here, where I had to follow up for about 5 months. Also got the oral max fax surgeon to have a look at it as well, just to make sure they've done a map of where the paresthesia is. The issue is we can prevent it by not injecting hypochlorite under force. So one of the most common problems is you don't realize most apical anatomies you cannot see on a 2D film, and even if they're not open apices, they may be slightly resorbed or open, and you can inject the hypochlorite under force. You can jam the needle in quite deep. So yes, you're doing the right thing by disinfecting. It is today, endodontics is all about how you disinfect and how you irrigate the canal. But I think some people can get it wrong by thinking if they put more pressure on it as it's coming out of the needle, then this is the thing. You just got to do gentle oscillation. You shouldn't jam it in. You shouldn't get the needle to get any further than middle of the root, really, on average. And it's got to be loose. And the side venting needles are very important here, because obviously the irrigant doesn't go flowing through the tip of the actual needle.
So you said the middle of the root. I had heard previously that we should be aiming for just short of the apex. Is that now not up to date?
Yeah. So no, I would say agitators can go further and agitate the irrigant, but again, careful agitation. You also don't want even your agitator, whatever that is, to also go through that apical.
You got to remember also the open apices or big sizes of the canals, they can actually increase the risk of having hypochlorite accidents, even if you're using normal pressure. There's also the periapical lesions, if they're present, reduced bone densities in anywhere. Actually, it's less pressure, back pressure from the tissues, so it increases risk of hypochlorite accidents. The other thing that I think will be noticed as well is that when you have fenestrations, so the root is actually all the way outside of the bone, there's not a lot of back pressure as well, so you need to be careful with your irrigation. Even if this is a normal irrigation pressure, then it's maybe too much for this particular canal, so you need to know. That's when CBCTs come in handy, because you can see where the fenestration is, you can see if the canal's too big as well.
I think I might give up on endo right now as a general dentist.
No, don't be disheartened.
Don't be.
Manny, when these hypochlorite accidents do happen, how should they be managed?
So the way, obviously, if it happened under my hands, I manage it is I stay calm. I take deep breaths. I don't go sweating over the patient's head. And, my sequence is, often you see bleeding. That's the first sign. That's the first stage of a hypochlorite injury. You're seeing unusual blood, like really, really red blood, and it's sort of flowing back into the canal. So the first thing is, please do not keep irrigating with hypochlorite, because that's where the second stage happens, where the patient will feel pain, severe pain, and you then know once they go, severe pain and there's a lot of blood, they're obviously in pain. And this is where you can give local anesthesia as a block or away from the site of the hypochlorite injury. You let the bleeding just continue, and you dilute the hypochlorite with saline within the canal. So you sort of just gently irrigate the canal to try to dilute it. And really, management-wise, then afterwards, is you monitor it for a while, you do a deep seal, you set the patient up, you explain what happened, and often I say what we used was very antibacterial, very good to kill those bugs. That was the aim, to reduce those bugs so your body heals, and unfortunately this is an inflammatory response, so therefore we recommend antibiotics. So there's three things: antibiotics just in case of infection, because obviously the hypochlorite is diluted away tissue, so there's more potential for bacteria to travel elsewhere from the tip of the root, and so antibiotic cover is essential. And then, of course, dexamethasone or something that reduces swelling, reduce inflammation, and reduce pain with anti-inflammatories, again, Neuromol, diclofenac, are the ones. Extra cold compressors are often used in the first day, and then after the first day, we might revert to warm compressors. So, and just reassurance and really getting the patient back to assess them is extremely important.
Well, Mona, you mentioned about using lower pressure in certain circumstances. Should we use a lower percentage concentration of hypochlorite in order to minimise the risk of accidents?
If you think that there is a high risk, there probably is a good idea to use a lower concentration. I tend to be careful as well because obviously we do irrigate and agitate our solutions. I would tend to be very careful with what I use for agitation because the techniques are different and they too tend to cause more some techniques cause more extrusion risk than others. So you put that in perspective and you choose which one according to the case. So it's not a cookbook type of thing. You got to look at what you're managing. So.
Well, Mehdi, you've been using MTA for a long time. This person has made an observation that it seems like MTA isn't really taught very much in dental schools. Do you have a sense of why that is and whether there's a way that can be addressed?
To be honest, I have used MTA. I sort of took it from the postgrad clinic in Melbourne, went to the undergrad clinic to help a student because I knew the sooner you seal the perforation, the better. The reality of the matter is, first of all, it's hard enough to do basic endodontics well. The other thing is you need magnification to be able to apply these materials and make sure that the MTA is used well, appropriately. So there's a skill factor, there's magnification, and it just takes time to teach students the basics. And I'd rather them do the basics right, get their rubber dam right. Having rubber dam right or diagnosis right, I think is more important at the moment than sealing a perforation. But down the track, as they do courses, definitely furcation perforations is something they walk away with on day one, where they think, okay, in their hands-on, they should be able to manage it as long as they find the canals and they can do the rest of the endo. In areas where there's no access to endodontist or patient has to travel a long way or they can't afford it, I highly then will suggest they will come to courses that they can at least seal furcation perforations if they're able to find the canals.
The other thing is that you remember that when you're disinfecting little perforations, you need to see them well so you don't remove too much of the tooth structure. So if you don't have that skill or training or equipment, then it might be a little bit difficult. It's not just about the use of the material. So, yeah.
Would you place an interim medicament of either calcium hydroxide or a corticosteroid paste while monitoring a hypochlorite accident?
Well, it depends on what you're dealing with. So if the canal was a vital case, there are some case reports where they actually just finished up the case or, obturated. But there are also case reports where they just left the canal empty. There's also other cases where they put some medicament inside. Most of these medicaments are calcium hydroxide. You just need to be careful not to extrude any of your medicament beyond the apex as well to increase more damage there, because the non-setting calcium hydroxide is very high pH as well. It can cause extra damage there, and it's already sensitive area.
And Mehdi, what dosage and regimen would you prescribe for dexamethasone?
Yeah, so I go by with the anaesthetist or the guidelines. I've spoken to a pharmacist about it as well. First of all, you only want to prescribe a few tablets, so that's 4 tablets at the maximum, maybe 6. And that's because the dexamethasone does come in a 30 tablet tube. So you need to instruct the pharmacist, we want 4 tablets. And it's 4 milligrams once every 12 hours with food. That's what I write for my script. And then occasionally, I know others do it slightly different. They do the half a tablet, which is 2 milligrams every 8 hours. So they both seem to have good effect. But I personally follow the anesthetist that I have, that 4 milligrams once every 12 hours, just 4 tablets. And they don't need to take all the 4 tablets. So if they feel that they're not inflamed, they're not swollen, they're not in pain, they can reduce it and not take all the tablets.
I prefer that they take them because I am aiming for that swelling to come down.
Yes, yeah.
Not just the pain.
Now, Paul, would your management of an iatrogenic perforation, is that different from how you would manage a resorption perforation, for example?
I think the principles are pretty similar. You still need to assess them like the prognostic factors that we did. The iatrogenic ones tend to be a little bit higher up, so they're a bit more easier to sort of get to. Some of the resorption cases we see can range from either external cervical resorption, but you can also get inflammatory resorption quite deep around those apical tissues. So it's all about disinfecting and it's about sealing. That's the end goal when it comes to perforation repair, whether it's iatrogenic or inflammatory in nature.
All right. Well, we'll take a short break now and then be back to discuss the hot topic of altered sensation in endodontic treatment, including damage to the inferior alveolar nerve and ways we can minimise those issues. This is where we say farewell to Dr. Muna Al-Ali this evening. Muna, thanks for being with us on the desk.
Thank you for having me.
Thanks, Mona.
Thank you.
Stay with us. We'll be back shortly. Welcome back. If you're watching this event via our Facebook simulcast, please note that we're not monitoring your questions. So if you'd like on Facebook, so please, if you'd like to participate in the discussion, head over to the URL on your screen where you can join us for free and let us know what's on your mind. We're now welcoming to the panel Adjunct Professor Chankrit Sathorn. Chankrit, thanks for being here.
Thanks for having me.
Perhaps you can help us with a question that's just arrived from our audience. Why might patients feel pain from a hypochlorite accident even though the patient is numb? When this person, administer LA for root canal treatment, I make sure the tissues are numb enough for me to extract the tooth. How then is the patient possibly feeling pain?
Yeah, that's an interesting question. I think it's not that you have a hypochlorite accident and you get pain. I think it's the other way around. As in, patient get pain and then we call it hypochlorite accident. I think the more interesting question is, does hypochlorite leak out of the canal during canal preparation? I think it does. Okay, this is not based on study or research or anything, but it's observation. When you look at the student preparing a plastic block or preparing extracted teeth, you can see droplets of hypochlorite leak out of the canal anyway. So I think that it's a matter of degree. Hypochlorite leak anyway, but if it's large amount or it's get injected under pressure and it diffuse to the wider area, it diffuse into a deeper tissues, then you can get pain even though you got numb beforehand. So it's a matter of degree, I think. Yep.
Okay. Well, Mark, our next endodontic complication to discuss is the hot topic of altered sensation during root canal treatment. Now, my blood pressure is rising just thinking about it. So how does altered sensation present in endodontics?
Yeah, so there's a few ways that it can present, and I'd say out of all the complications that you can have happen in endo, this is probably by far the most stressful as a clinician to deal with, because sometimes you can work to mitigate it, but sometimes it can take you by surprise as well. And it can present in a couple of ways. So first is just full-blown anesthesia. The patient never regains sensation after the anesthetic's been given to them, but that's at one end of the spectrum. They can also have a degree of paresthesia, pins and needles, or they have a sensation but it's not quite normal anymore. And then there's probably I'd say one of the worst complications of hyperalgesia, where now they're getting more of a neuropathic response where they're having pain in response to normal stimuli. And you can get that spectrum of responses in regards to altered sensation after endo treatment. Now, the saving grace is a lot of the times these are temporary. They last anywhere from a few days up to 6 to 12 months. From when you look at the literature, typically if it's going to resolve, it's going to resolve within 24 months. So you can have to monitor these over an extended period of time. But unfortunately, in very rare cases, it can be permanent. And that's the big stress, because you monitor these patients over time, hoping every time that you call them or they come in that they say, I felt something, because then you feel a lot more comfortable moving forward with it. They're incredibly stressful.
So what are we looking at on this image?
So this is an image that was sent to me a number of years ago, and you can see how radiographically the roots don't actually look like they're that close to the inferior alveolar nerve. I don't think anyone would look at that and say that's a danger zone for an extraction or an endo, but we have to remember that bone is porous, and all it takes is a little bit of a marrow space to be between the root tip and the inferior alveolar canal. And as we place our gutta percucones within the canal with sealer, sometimes the sealer can get a little bit of a puff, and instead of a puff just wrapped around the apex, a little bit can track ended up in the inferior alveolar canal like it did for this clinician. And at the time, if I recall correctly, the clinician was asking me, what do I do at this point in time? The patient hasn't left yet. They contacted me, sent me the radiograph and said, can you please give me an opinion about this so that I manage them appropriately before they leave? And at this point in time, you can't put the genie back into the bottle. The sealer is there. Seal up the tooth as you're going to normally, and now we need to control what that sealer is going to do to the inferior alveolar canal, which is placing the patient on the dexamethasone to reduce what sort of inflammatory response is going to happen afterwards. Because whilst the sealer itself is going to set pretty quickly, the reaction to that sealer is what we can control. And thankfully, in this case, the patient didn't have any sort of neurosensory deficit. They were on dexamethasone for 3 days. And similar to what Muna touched on earlier, even if they're feeling better, I want to make sure that anti-inflammatory response is happening over that full 3 days to reduce the chance that they have a delayed paresthesia, which can also happen, especially in result to a flare-up in a tooth that's really close to the IAN.
So when should we refer to an oral surgeon, for example?
So in a situation like this, the step one, if it's a patient seen in the morning, you contact them, say 3:30, 4 o'clock in the afternoon and say, how is everything feeling? Did the anesthetic wear off? And if it hasn't worn off, you get on the phone to your local MaxFax and explain the situation, and then you let them take over with tracking how that paresthesia and anesthesia progresses. And that might be a very short amount of time before everything goes back to normal. But the last thing you want to do is leave this up to chance and then leave the patient for weeks and weeks and weeks, because if they're going to manage something surgically, which they're probably not going to in a case like this, they want to get on top of it quickly. But realistically, doing surgery to remove something like extruded sealer into the inferior alveolar canal is going to cause damage in and of itself. So the last thing we want to do is intervene, but you do want this monitored by an expert pretty quickly in the piece.
And you've obviously, presumably informed the patient that there's been some movement of materials into an unusual space.
Yeah, exactly. And that's the whole thing, keeping the patient in the loop as to exactly what's going on. In the process of treatment, a bit of material has extruded. It's right over the nerve canal, and that's going to cause an inflammatory response. There is a chance you're going to have a degree of altered sensation. My hope is that this is going to be temporary, but it can be permanent. You have to let them know, obviously, what to expect over time, but that's why you're putting them on the steroids, and that you're letting them know you're going to keep in close contact with them over the next couple of days, couple of weeks, couple of months, whatever it happens to be, and that if they're still numb, say that you treat them in the evening, they're still numb the following day, that you're going to get them to see the local MaxFax as soon as possible. So just letting them know that you want them to get better and you very much care about them having a positive outcome at this point.
And how can we assess perhaps the level of risk of these nerve involvements?
Yeah, so a lot of it's just good radiographic technique. So obviously you need to have a good radiograph pre-operatively before you're treating a patient. And examples here, so this is a film from a general dentist sent me a couple of years ago where they've done an excellent job maintaining the root filling within the root canal space. But the beautiful thing about this film is you can actually see the inferior alveolar nerve canal deflected by the root. So when you see something like that, you know that there's going to be a degree of intimacy between the tips of that root and the actual inferior alveolar canal. And then looking at the literature, I know when I was a dental student, you'd look at these and you go, right, I've got to memorize what this looks like for an OPG or a PA, because they're going to tell me whether the roots are close to the inferior alveolar nerve or not. But nowadays, I would argue that for a lower molar, where there's even a degree of uncertainty as to where that nerve can be, we have the technology, we need to use it. And I'd be getting a CT scan or a cone beam CT pre-operatively in a case like this, just so that I know whether I need to lose sleep or not, but also so that I can adequately warn the patient, so that I can keep them in the loop of, do they want to do that root canal treatment anymore, knowing that there is a biological risk that could be quite devastating. So here's an example from, this is from my own clinics. The patient wasn't sent to me on this image on the left for the 3.8. They were sent to me for the 3.7. But I notice on the imaging for the 3.8, you can see the line of the inferior alveolar nerve going right over where the tips of those roots are. But when you see on the CBCT imaging, the inferior alveolar nerve canal is so far away from that lower 8. It's a two-dimensional picture of a three-dimensional object. So you're not going to be too stressed out if you had to take out that 8, for example, or, God forbid, do endo to that tooth. But then you've got the CT slices on the far right and in the bottom. That tooth on the far right, the actual tip of the root isn't close to the inferior alveolar nerve, but the lesion is butting up against it. And after you treat a tooth, there's going to be a degree of swelling. I always say to the patients that doing endo treatment is like popping a pimple at the end of the day. You get the gunk out and the area is going to get swollen, and that's going to happen at the tip of their root. And as that lesion wants to expand with inflammation, that's going to cause compression over that inferior alveolar nerve, and the patient might notice they've got some pins and needles or tingliness or something like that. And even though I mentioned that it's far away from the nerve, and you can measure these on CT scans, it's only 1.5 millimeters away. So far away is also relative, because our apex locators have a degree of accuracy plus or minus 0.5 of a millimeter, and they're not always accurate. Sometimes they're very much inaccurate. So again, if there's any degree of closeness or proximity, you're probably going to want to have a working length film and not just rely on your apex locator in a case like this too, because it's very quick and easy. 1.5 millimeters is not that far.
So how far away would you be more comfortable to work with and don't lose sleep overnight?
As far away as humanly possible.
So 2 millimeter is
the maxilla. If they were all in the upper, no, it's I think to myself, how far of a tolerance would I like? Probably about 2 millimeters, because I find in my hands and in the past when I've taught, for example, you don't tend to be more than 2 millimeters out the apex, even if you're a little bit long, because you've got an estimate of how long that root's going to be radiographically. And if you're going longer than that and your apex locator isn't singing, you're probably taking a film to confirm what's going on, because we've all had cases like that where our apex locator is just not telling us what we know it should be telling us, and we get a scan, do a film, and we see what it shows.
I mean, apart from calibrating the apex locator, which is a topic on its own we could discuss, I think what I found these days is those small field of view Combeam CT slices, you can really measure up very accurately.
They're really good, and the measurements I find are accurate to within about a millimeter. And that's enough of that tolerance level of, okay, you might go to instead of the plus millimeter, minus a millimeter, and take a PA just to go, okay, I'm pretty confident and comfortable with where I am. But it's just a matter of getting that extra bit of information, and as difficult as it is to take a working length film of a lower 7 or 8, it's ensuring that you're doing it. And also being a little bit paranoid. I don't know about you guys, but I lose sleep. It's just teeth, but I lose sleep over this stuff. And here's an example of my own from a couple of months ago. And a patient came in, it's a lower 8, but of course they're missing the 7 and they wanted to retain it. On the surface, it looks like a regular endo of a lower 8, but I've been tricked before, and when I looked at the inferior alveolar nerve canal on the PA, I didn't necessarily think it was close, but I explained to the patient that I want to be paranoid because this is a lower 8 and the bone's thinner here and the nerve can sit higher. Do you mind if we get a CT scan? Because I want to make sure that I keep you safe. And it's all about patient safety. And the patient, yep, get a CT scan. And that's one of the slices from the scan. But more importantly, I asked the radiologist for a report to confirm what's the relationship between the inferior alveolar nerve and the roots. And as you see on the report here, the root is inseparable from the inferior alveolar nerve canal. So immediately my heart rate jumps a couple of octaves if I have to do treatment to this tooth. And I sat the patient down and I explained to him that this is the situation. If I treat this tooth, I'm going to have to stay further away from the apex that I would like from a technical point of view. So I'm going to give you a compromised technical outcome, but that will mitigate the risk of a biological complication that could be quite devastating. Or alternatively, if you're not comfortable with that, the tooth's stable, we can leave you as is until you're comfortable to do something, or you can go down the path of extraction, which again still has that same complication risk that something could happen to the inferior alveolar nerve, but the pressure that happens after the tooth is out has an entire socket to expand into rather than expanding down into that bone we don't want it to do.
Now, we talked about dexamethasone prescriptions before. What kind of dexamethasone prescription would you provide in the case of sealer extrusion?
Exactly the same as what Mehdi explained for the hypochlorite injury. I want to hit it hard, and I want to make sure that there's the lowest chance of inflammation possible in that first 48 to 72 hours. So we're looking at Dex 4 milligrams, or dexamethasone 4 milligrams, 1 tablet twice a day for 3 days. And I asked the pharmacist to dispense only 6 tablets. Obviously, some patients can't actually tolerate the dexamethasone. We have to make a mention of that. Diabetic patients, it's a contraindication. Some patients that can't tolerate anti-inflammatories in general. We've got to make sure that we keep our patients safe, but also dexamethasone can have some cardiac side effects. I've had patients explain to me that it feels like they've had 30 coffees, they get tachycardia, and the heart rate goes insane. So if there's any weird medical history stuff, it is good to clear that with the doctor to make sure that they can actually take the anti-inflammatory, and if they can't, then it's stuck with paracetamol and hope. Which is a very strong medication we use on a regular basis.
We all love a bit of hope.
Yeah.
Mark, in the instance of a hypochlorite injury or cement extrusion, should the cost of the specialist referral be something that the clinician who was treating the patient at the time of the incident pay for?
So this is a really multifaceted question, because technically you obviously didn't do the complication on purpose. None of this has happened because we wanted it to, but we have a patient here that we need to look after. So because of the fact that this is something that's going to require other specialists to be involved in, after you've called the specialist and after you've sent the patient on their way, the next phone call is likely going to be to your indemnity. And the best thing you can do is follow your indemnity's advice, because they are going to guide you so that you handle this with as least administrative complications as possible later on down the track. But personally, from my perspective, if you have a serious complication like this, I find that it's just good people management, is to just offer to the patient that, look, whatever the fees are from the surgeon or the endodontist, you don't have to worry about that. You pay them and I will reimburse you. You just bring me the invoices. And that way the patient doesn't get the extra sting of further fees on top of the complication that nobody was expecting. It's just looking after people at the end of the day, because we want to make sure that they do feel like they've been taken care of.
And Chankrit, would you employ a particular or a modified obturation technique? Mark sort of commented on a little bit on this, but in a case like this where it does seem as though the apices are very close to the inferior alveolar nerve canal, would you modify your obturation technique in any way?
Yeah, most of the time we do a warm vertical condensation, or you're using thermofill, gutter core, that sort of thing. But with this kind of cases, because we don't want any extrusion of sealer, so probably lateral condensation would probably be the way to go. And be careful with the way you place the sealer. Yeah.
Okay. Well, Paul, fractured instruments are a part of endodontic life. So what can you tell us about how we can reduce and manage them when they happen?
Yeah, I just think fractured instruments are, like you said, a part of endodontics, and they do happen. And I think there's two ways to think about stress: the stress for us and the stress for the patient. Stress for us, we want to think to ourselves, well, is the tooth still going to be able to respond to our treatment? Is it going to heal? Now, these aren't very common occurrences, so they're hard to really study in a prospective manner. It's also a bit unethical to study fractured instruments in an in a prospective manner. You got to sort of look at them with what's the highest degree of evidence that we have in our literature, and that's with retrospective case-controlled studies. And there's two that we have at the moment which are high quality. One's come out of Melbourne from Peter Spilly's group, and it says that perhaps it's not so much the fractured instrument per se that is the prognostic factor, but the presence of the periapical radiolucency instead. So it doesn't really matter, no, because if it doesn't hinder our chemomechanical instrumentation, it shouldn't affect the prognosis of our teeth. The other side is patience and communicating it with them. And the first thing that I get with my patients is, so there's this piece of metal that is stuck in my tooth. And you got to sort of break it down a bit and explain to the patient what's actually happened. Number one, the size of the instrument is very small. They can be millimeters, they can be 2-3 millimeters. Yes, they can be quite large sometimes, but they're relatively small. They're also sterile, biocompatible nickel titanium. And I don't know why we stress so much, because we use titanium implants all the time. Our orthopedic surgeons place metal into a lot of their surgical cases. So we need to explain to the patient that this is not a problem per se. It's not going to react with the body if it's inside the tooth. And I think that's probably going to be the best way to sort of explain it to our patients. What we can sort of see in the coming slides, we've been using metal as well in endodontics. We've used silver points, we've placed posts to restore teeth. But I think one of the most exciting things, there's a radiograph that is coming up, and I'm going to get Mark to explain this, because when he told me what this was, I was actually extremely interested.
Yep, so the image on the left here, so this comes from a publication, if I remember correctly, it was ZIAS, Z-I-A-S, back in the 1980s. I could be absolutely dead wrong, and someone in the comments please correct me on this. But this comes from the skull of a soldier in the region of modern-day Iraq, and it dates to about 200 BC, and this is the first, I can say, anthropological evidence of endodontic treatment. So this upper three had actually had the canal prepared in the coronal portion, and it had a piece of metal had been fastened into a tube and plugged into the tube. So the basic principles of endodontics of core out the top and place something as a plug had been applied, but obviously, not to a standard we're satisfied with today. But you could always say to a patient that historically, metal was the first material of choice for endodontic treatment. I mean, quality aside.
Well, Mark, would you discuss the possibility of instrument fracture with your patients as part of the pre-treatment consent process?
Yep. So I do that as my standard. I find that part of informing the patient of the instrument fracture isn't just saying, oh yes, these things can break. It's also giving the patient a context to, well, what you're doing and how it works. So if you say to a patient that, oh, I've just broken a portion of an instrument, or I've separated a portion of an instrument, they almost think of it as you've left surgical scissors in their stomach afterwards, because that's the leaving something behind that they're used to. So all of a sudden that just builds up the heart rate and the stress of the whole situation. And I do love this quote from Dr. Bruce Drysdale, who was the original CRO, Community Relations Officer at the ADAVB. And patients tend to forgive just about anything if you warn them beforehand, but if you don't, and then something happens afterwards, they tend to be very unforgiving. And I see it as, if you explain to a patient what can happen beforehand, it's a reason, whereas if you tell them afterwards, oh yeah, it happens, it becomes an excuse. And it's just that mutual respect of letting them know that this is something that does happen, and it happens to everybody, even the most careful endodontist out there or dentist out there. It's going to happen. You're going to break an instrument. The only way to avoid breaking an instrument is to be an orthodontist.
So what are your thoughts on these coming slides?
So when you look at this, there's another, I guess, reason to explain to patients about instrument fracture. It's a very common complaint in endodontics. When you look at any study that's actually gone through why do patients complain in endo, instrument fracture features quite heavily as one of those reasons. And factoring into that as well, consent-related complaints are also quite common in healthcare, medicine and dentistry, and in Australia. So forewarned is forearmed. And again, it happens to all of us. If a patient says to me, you will not break an instrument in my tooth, that's probably the patient where it's going to break, just to make a liar out of me if I said that it's not going to happen. So I say to patients that, look, it happens to everybody. We use very flexible instruments, but unfortunately, it's not perfect, and sometimes they do separate.
And Chankrit, have you always included instrument fracture in your pre-treatment discussion?
When I first started, that's 20 years ago, I'm very, very against talking about fracture instrument during a consultation, because biologically, fracture instrument doesn't do anything. It doesn't change the outcome. So to us, it doesn't make sense to talk about it because it's not going to do anything. But I think over time, I've become more mellow, and I think that people don't make decisions based on hard facts. People are complex. Even though we know that it doesn't make any difference, biologically it doesn't do anything, but psychologically it have a big impact on the patient. So we might as well talk about it before it happens.
And Paul, how can we go about reducing the chance of instrument fracture?
Yeah, I think you sort of need to understand the properties of nickel titanium and radio instruments. It also happens in hand files as well, but a lot of them can fracture without any warning. So what are some of the things that we can look at? And it's really about keeping it kind of simple and sticking to the basics. Ensuring our access is of decent size, that we're not going to be putting too much stress on our instruments at the shank. So essentially going for a straight line, access where we can. A crown down approach, where we're going to want to remove a lot of that coronal dentine first. It's going to reduce our taper lock on the instrument, so we're not going to be putting significant force on the full length of our instruments. At the same time, we should always be instrumenting with irrigation in the canal. It's going to act like as if it's a lubricant. I think one of the most important things is patience. And I know I've been at fault of it. You sort of want to do this as quick as you can. The patient's a bit annoyed, but you need to be patient with it. The instrument's going to want to go down by itself. You can't really be jamming these things down. Once we put extra force on these instruments, they're going to want to break. We're going to exceed that elastic limit, they will break. One thing that I think is very important is inspecting our instruments once we've used them. Now, a lot of our instruments go through a sterilization protocol, but ones that have actually done quite significant amounts of work, if you look closely, you'll start to see little defects in them, either unwinding or twisting. Those are the ones I would not put back into a canal. Discard them. Get rid of them. It's not worth your time. Just too much headache, to be honest. And finally, cone beam CTs. We look at a 2D radiograph, and it doesn't give us as much information as what we want. There's going to be curves inside canals, there's going to be isthmuses, there's going to be ramifications. There's so many complexities inside the canal that can easily sort of pick up an instrument, bind, twist, rotate, it's fractured. So the more information we can get with 3D imaging, the more we're going to be inclined to either be more patient, take care, or even forewarn the patient at a bit of a higher level for significantly kind of curved cases.
All right. We've had a question about how people can go about rewatching this episode. It will be available to watch on this viewing page for the foreseeable future, certainly for the coming days. So if you want to rewatch, pop back and you can catch up again. Mehdi, when a fractured instrument does happen, what should we do?
Okay. First of all, don't stress. That's the first thing. It's the same with I think it's probably the same with every complication we're discussing. So often what I do is I continue treating the patient until the end of the treatment when I've done my seal. And then when the patient's sitting up, rather than sweat over them and try to talk to them while it's happened, I get them up and I have a conversation with them. I might pick up a file and show it to them. That's how I do it, and say, look, this file here, the anatomy has stressed the file, and unfortunately a little bit is separated inside the canal system. And sometimes, obviously, a dentist may be able to manage it, but most often, if it's a dentist, they would then say, I want to refer you to a microscope specialist who has a microscope, who's able to have a good look at the case and see whether it's retrievable or not. Please do not tell patients that we're going to remove the file and send it back to you. Don't worry about it, she'll be all right, because that's just not what happens all the time. I'm not going to remove a file that has the canal's already clean. It's the final finishing file. It's wound at the apex and there's no lesion, for example. There's no symptoms, so it makes no sense. Occasionally I get dentists sending me cases prior to referral, and sometimes I say, well, if the patient's so adverse to having costly treatment, at least get them to come in for a consult. And occasionally I do my consults for them just to look after my referral group, and they come in, I explain it to them, I tell them the papers by Parashos and Messer that we read in 2006 and those years, and I basically explain that, look, I actually fracture more files than the dentist who referred, because I do more endo, and at the end of the day we don't worry about it, because at the end of the day, in many occasions the canal's already clean. The basic principles of endo has been met, and we shouldn't be worried about removal, because often if we do remove, we can weaken the tooth, which is more important, because the tooth will fail not because of the endodontic failure, because of the fracture. That the restorative failures and the fractures are more common.
So then, what, in terms of a hands-on thing, we've covered communication, what can be done around an instrument fragment?
So first of all, where is the instrument? So I usually divide the tooth up into the coronal third, the middle third, and the apical third. So I put that in my head. I go through flow charts that I have in my head from papers I read, such as Parashos and Messer. And then following that, I inspect where the file is. And if I can see the file or I can feel the file, can I bypass the file? Often 1 millimeter files or 2 millimeter files are bypassable. So you're able to spend time bypassing files. In the next slide there, if you switch on to it, you could see there's a lot of space there, especially with the case on the right, where you'll find a way around the file. So the file then can be incorporated into the root filling. Occasionally it flushes out. You don't need to worry about if you're able to achieve what you need to. And in cases where actually it's very important, is the cases where maybe it was an early file that fractured, and often those files are smaller, they're more bypassable, and you're able to get to your patency and you're able to get your irrigant there, and the case should heal, as per if the file wasn't there. In some situations, removal is indicated when you have a microscope, when you've got experience. As time went on, my accesses to these instruments got smaller, and I always follow Nigel Sauter and Jeff Ward's papers, where beyond that curve, you don't realize how much damage you're able to do and how much tooth you remove unnecessarily and how much you put that tooth at risk of fracture. So therefore, in many cases where I can't see it or it's beyond the curve, I wouldn't even attempt removal. I'd think of, if I have to, surgical approach to that case. And in cases where I can see it, with conservative measures, such as, I'm going to have to admit, I have a vested interest in the next topic, which is talking about the Yoshi Teruchi visit to Australia and the Yoshi Teruchi kit. You sort of see here removal of these instruments, what they might be, in this case the silver points, by using ultrasonics that are very fine. I can see it under the microscope, it's very clear. I can actually, once they're semi-loose, get my Yoshi loop on it, and these days the Yoshi loop is much more robust, and we're able to then grab and pull that instrument out. So in the middle of the root, once you loosen the instrument using lubricants such as EDTA, for example, then you're able to remove it using the loops. And the loops used to break before very often, and they were very annoying, but these days, thanks to Yoshi and I guess the technology by Woodpecker, we're able to now grab them and put, as you can see, quite a bit of significant force on that particular silver point or file, and you can see I'm really pulling, and I'm able to, it doesn't break the loop, and I'm able to remove them. So I think the moral of the story is, do you really need to remove them? In this case I did, because the canal, there was an apical lesion that you can't see. So there's another system, just not to have too much bias, in the next slide. So we've got the Zumax retrieval kit, and I believe, Mark, you've used it. Maybe it's quite good, or
I haven't used it, but they do have a very small caliper. I've seen it in use. They've got a really small caliper. So sometimes when I look at a fractured instrument or a fractured thermophil carrier, for example, and all I want to do is just pick it with a pair of tweezers or something. The tweezers are too small to get it, but the Zumax kit, I've seen that it does have a tiny little caliper that I'd imagine would be able to pick something out, but I haven't actually got to try it out in person.
So back to microscopes. Don't forget, you need microscopes and you need training to do this sort of stuff.
So we shouldn't be launching into this with no experience.
Don't go tomorrow to the practice and go, I'm going to use the loops. Yeah.
Okay, read a microscope. Shankar, do you find that file fragments affect or meaningfully affect the prognosis of affected teeth?
I think the literature seems to suggest that no, it doesn't do anything, and even with fracture resistant, the retained fracture instrument doesn't affect the fracture instrument as well. So the only downside is probably it's about disinfection. So fracture instrument can have some negative impact on disinfection, but that depends on the stage of the canal preparation. It's on the next slide. So if the fracture happens early on, yes, logically speaking, it should have some negative impact because we haven't been able to clean the entire canal. But if we already clean the entire canal and it fractured, then it shouldn't have any impact on the outcome.
Well, Mehdi, have you ever fractured an instrument whilst trying to retrieve a fractured file?
I think everyone sitting here has, to be honest with you. And my final pointers are, guys, avoid chain of misadventures or chain errors, if you like. So as you can see with this car, and then the truck falls in, and then another truck goes to recover and falls in. So it has happened where we didn't bypass or we didn't use hand files and we fractured a file in the second file. patient came in with 1 fractured file, they left with 3 or 4. I don't know what the record is, Mark.
I don't know. I've had a case in my postgrad days where it was a fractured instrument from the undergraduate clinic, bypassed it, fractured the file that I bypassed it with, great, bypassed that, fractured another one, great, got 2 of them out, left the original behind and completed the treatment. But it happens, and this is why it's really, really tricky to deal with these cases, because even in our hands, things sometimes don't go to plan, which is why if we're going to manage this, I do inform the patient that dealing with this instrument, we're going to try and bypass it. I use the analogy of, I draw a little picture to exaggerate the tines and the grooves on the file and go, as this is spinning, it could lock into these grooves and separate, and the patients look at that and go, that logically makes sense. It's not just a long, smooth thing. It's actually got these little teeth in there that can chew into it. So, but yeah, I think it's happened to all of us at least once.
And Mehdi, if a fractured instrument is more than 7 millimetres long and is wound at the apex, does it seem to you as though it might be possible to remove it using the kit that you mentioned, assuming this person has a microscope?
Well, it depends on if it's straight down that. So let's say there's a lesion, okay? Let's say there's persistent symptoms or there's a lesion and you really need to remove it. In many cases, obviously, you don't need to do this and you shouldn't. But if the canal system is straight and wide and you've checked the CBCT and the root's quite robust, it is possible to remove it. I know Yoshi Teruchi does. I prefer, with those cases, to approach it differently, because I know that occasionally I've fell into the trap of ultrasonicating the 7 millimeter instrument. It is possible to remove, but sometimes it's quite tightly wound. But certainly if you're able to see it, the loop should be able to, just like you saw in that image with the silver points being quite tightly wound, you can actually pull it out. Yeah, you can wind it and pull it out, wiggle it out.
All right. And one of your big sayings, Mehdi, is to believe in the biology.
Yeah, so my point is that it's been a very negative topic. I mean, Muna asked me, why did you start with this episode? But I think it was one where I think a lot of people in the past, like a lot of dentists, have really stressed over. So I wanted to help reduce their stress. So believe in the biology, believe in the fact that endodontic treatment works, as long as the tooth is not cracked and you're able to clean most of the root canals. I mean, 50-60% according to the studies by Ove Peters. That's the body heals, the bacteria goes below a threshold that causes disease, as you can see in this case. So the story is the patient was very accepting to have treatment in the grey area. For example, we didn't take the crown off because he knew it's 50-50, but his expectations were low and he wasn't ready to have an implant. He was a plastic surgeon treating cancers and half his patients died. So this wasn't bad, it was just a tooth. So what we did is we medicate the 6 in particular. They had an old perforation, as you can see with that crestal bone loss there, the furcation bone loss. The MTA went through, it's resorbed out there, and then bone came back, and you can see the 13-year review. Everything's been quite stable for this patient, and even the fractured file didn't make a difference because the CBCT proves that the canals join. And the other point I wanted to make is often when you look at the CBCT, look at where the canals join, those mesiolingual, mesiobuccal canals that join up, or the MB1, MB2 canals. Quite commonly you can separate a file because there's a 90-degree curve that you cannot see. Thank you.
All right. Well, we have about 1,000 questions to get through, so I apologise in advance for the questions we don't get to. Your questions are anonymous, so I promise it's nothing personal. Paul, do you ever reuse rotary files after sterilisation, or do you prefer a single-use approach?
I think in the ideal world, if you can do a single-use approach, then for sure. But files and instruments are pretty costly, so we like to use a sterilisation, protocol for those reasons. You also, like the way that we work, we sort of have our own kind of packs where the instruments have come out of their blister packs and they're all sitting kind of nicely in their sponges. So they all go into steri at one time. Sometimes after a case, I wouldn't have used maybe 50% of those cases or those files. So those are the ones then, if we're just going with a single use, they're all going to get thrown out. It's a bit of waste. But I like to say I do reuse those instruments if they've done significant amounts of work in a canal or they have visual defects. I will not reuse them. I will throw them out. And that's my protocol.
Speaking of visual defects, I heard that some rotary instruments do not show signs of fatigue when looking at them. Is that true?
You got to assess it in terms of 2 modes of fracture, either torsional or cyclic fatigue. So cyclic fatigue is going to be around a bend and it's going to be consistent kind of work hardening of the metal. That will fracture with no signs of defects. A torsional fracture, that will show signs of defects where it will bind at the tip or somewhere along the instrument, and it will continually rotate and unwind. So the question is technically correct. It can break without any signs of defects, but it's very rare for both of these modes of fracture to occur not simultaneously inside an actual canal.
Matty, would you routinely take a CBCT prior to every case?
Well, I've given lectures on CBCT, and when I first started giving lectures, I was not recommending it, and I went by the principle of ALARA, as low as reasonably possible, and most often we do compare reviews with 2D images. But however, since then, I've changed my view, almost like Shankrit talking 20 years ago. So since the Jurassic era, now that we're in this era, and I know that the CBCTs we take are very low radiation and they're safe, really, low field of views. I feel that every time I take a cone beam CT of even the world's most straightforward, say, upper incisor, I just get more information. I can be more conservative with the way I manage it, and sometimes you see things you didn't expect. One of those ones which I just saw today was the upper maxillary area, and I just could not see the lesion and the reaction in the sinus until I took the radiograph I took. I couldn't see a thing. And the other one where it comes to mind, which is very handy, is cracks. The cracks are so difficult to pick. And the cone beam CT does make your job a lot easier because those lateral bone loss, or what we call chimney defects along the root, can be seen. Even those subtle bone losses, they can be seen, and they're highly suggestive, of course, together with clinical investigation that we're dealing with a crack.
Chankrit, there's been a lot of interest in recent years in Australia and around the world in considering pulpotomy as an alternative to full root canal therapy for management of irreversible pulpitis. Could this be a viable option in cases where full pulpectomy might risk hypochlorite injuries, inferior alveolar nerve damage or perforations?
I can see the future going into that direction, but we're not there yet. I think the best literature on this topic is Taha 2023, but the sample size is about 60 cases altogether. So they compare pulpotomy with full root canal treatment, and they found it non-significant difference in terms of success rate or healing rates. But this is what we call a non-definitive, non-significant result, which means that the sample size is not large enough. So that's why I say that trajectory is going in that direction, and I think eventually that's going to happen.
And Matty, one of our viewers has heard about zirconium oxide MTA. We talked a bit before about discoloration with the products that are more broadly available. Do you have any experience or information to share on that front?
Yeah, so watch this space, because everyone has been talking about discoloration with MTA, but still a lot of endodontists like myself really love using it. I have used biodentine. It's a bit sticky, or other bioceramics, and they don't also have the long-term studies and the histology behind them. For example, as biodentine in a long root, if you've got a deep perforation or if you've got an open apex, it's very hard to apply. I've tried it, and it's just very challenging. So I think MTA, because of the good properties of it, because actually the handling properties, once you know how to use, is actually quite straightforward. The fact that you can wash it out and put it back in, the fact that it's radio opaque. Zirconium oxide MTA is coming out on the markets, and one of the ones Professor Torbanijad's been involved in inventing has been released in the States. It has FDA approval, and there's another one in Europe that is also, I know it's on the market. So it will come to Australia eventually, and it will, I guess, get rid of the stress of us not being able to use the best material, in my opinion, my humble opinion, because not everyone agrees with that opinion. It's an opinion.
And Mark, would you ever consider using a higher loading dose of dexamethasone, or would you stick with every time the regime you mentioned?
That's a really good question. So I guess the problem that we have more than anything else with hypochlorite injuries, altered sensation, you name it, is that the literature is at a very low level, because they're all case report, case series, expert opinion. So we don't really have good data on if you do this, you get a better result. If you give a loading dose, you get a better result. Or if you don't, you get a better result. So the regime that I use is based on experience, chatting with senior colleagues, and chatting with max faxes in the moment sometimes, I guess you could say. And I've never been recommended to give a patient a loading dose. And since I'm not a medical doctor, I feel that once it gets to the point that there could be altered sensation or a hypo injury, that's getting almost into the realm of medicine and the maxillofacial side of things. I rely on their recommendations rather than trying to assert myself then. So I'd be sticking to the Dex 4 milligrams twice a day until, I guess, advised otherwise by someone with more experience in this and I guess more expertise.
And Jan, returning to a question I asked you when you first joined the panel, would it be possible to recognise a hypochlorite accident on a sedated patient?
Very interesting question, but I don't have a good answer to it.
I can answer
I
it,
think
yeah.
you can, yeah.
Depends on the level of sedation. So if they're, I guess, depending on the drug that they've been given, often you don't want to go too deep. So like most of the sedationists, there's an art to giving sedation. You certainly can tell when the patient's heartbeat does go up and they feel discomfort. So yes, you can. Not only you see the blood, which is, I'm telling you, it's like bright red. It's not the usual oozing blood you see in a pulp tissue. Secondly, you can tell the patient's in pain. So you just got to watch your senses, and a good anaesthetist will be able to tell you when the patient's uncomfortable. And luckily we have one, a gentle endo, I won't name, but he's very good. He doesn't want to be mentioned, but he actually does tell us a lot more than you think. From breathing, paying attention to signs of breathing. I've learnt a lot. How the jaw posture is, all the way to the patient's not comfortable. I'm telling you, they're not comfortable. They're either not numb enough, they've still got an inflamed pulp tissue, or perhaps we're dealing with a hypochlorite injury, God forbid.
And Paul, would you ever use a lubricant such as EDTA gels to reduce your risk of instrument fracture?
So I do use EDTA, but not as a gel. And I don't ever recommend using anything as a gel. I just feel like it's going to go into a canal that may not be able to sort of come out and actually clean very well and very effectively. And all the literature on gels inside root canal treatment have no significance
Actually,
whatsoever.
the literature seems to be the opposite.
Yeah.
If you use RC prep, more likely to get fracture. Yeah.
All right, do we have a sense of why that might be?
I don't understand it as well.
I've been told it clogs up the flutes quite a bit, and we do see that. Whereas with the EDTA and the hypo, it's fluid the whole time, whereas the RC prep does clog up and get quite gluggy, so it increases the amount of stress that's on the file.
And Shankrit, is it possible to see isthmuses on CBCT?
If you really look at it, sometime, but I don't think it's a guarantee thing. Yeah.
All right. And Mehdi, one of your pet topics, we from time to time have patients resist the idea of endodontics after watching things like the Root Cause so-called documentary. What is the way you deal with patients with those concerns?
Yeah, so I mean, you got to go back to the Root Cause documentary. It's Pulp Fiction, which we did a number of years back. I would try to discuss a logical topic with them. Occasionally, the patient's already got an opinion, so it's very hard to, even with logic and with science, discuss it. Okay, so it depends on that patient, because sometimes they come in, they already, for example, know the diagnosis, they already know what they want, and it's like, why are you here? You're here to challenge endodontics that's been done for years, that works in many cases, provided, as I said, the tooth is not cracked or we haven't missed something. It should work, and in many cases does, and we're dealing with a lesion encapsulated, if there is a lesion, because sometimes there's no lesion, it's a vital pulp, irreversible pulpitis, let's call it. So the reality is that it's in a confined space, and we know that bacteria, even within other areas of the body, like a bowel motion, can be introduced into the bloodstream more than the bacteria that's in a confined space in a avascular, really bone type tissue. So it is very unlikely, unless the patient's got fever, cellulitis, really sick, that this will actually have effect anywhere else in the body. And root canals, you're not going to read anything on it. If you sieve out the literature, if you look at the good quality papers on talking about cancer, root canal links and all that, they're just a load of nonsense.
All right. Well, Mark, should we use a resorbable cement in cases where we are close to the inferior alveolar nerve? Do resorbable cements exist?
That's another good question. See, from my experience with cements is that you want to have something that is going to set, because if it's something that's resorbable, odds are it's going to dissolve out when it's inside the root canal system anyway, so it's not going to be a technically adequate seal for your obturation. So you're almost robbing Peter to pay Paul with that one. And from my view, even if it's resorbable, that initial inflammation that cement that gets extruded is going to cause some degree of inferior nerve damage. And even if it disappears over time, the AH plus that's set technically over the inferior alveolar canal, that AH plus isn't causing chronic irritation over the next 20 years. It's caused its irritation, now it's set and it's just there for the most part. So I wouldn't be recommending a resorbable cement. I'd just be recommending, I guess, better length control when it comes to the obturation, and not filling up the root with so much cement that it looks like a swimming pool. We want to have a minimal amount of cement, and thankfully, due to our rotary instrumentation systems that come with matched taper GP cones most of the time, you don't need a lot of cement at all. And as you're placing that GP cone down into the canal, you have probably gone shorter than you would have liked in an ideal world, and you're just gently placing it down, so that hydraulic force is going to want to push this excess sealer coronally rather than apically.
All right. Chankrit, sometimes I agitate the irrigant with the endo-activator instrument, and the irrigant seems to disappear. Do you think that it's leaking?
Probably it's come out coronally rather than epically. Yeah, logic seems to dictate more like it.
And Mehdi, you talked about sometimes not trying to actually quite frequently, not trying to retrieve instrument fragments. Would you be more worried if an instrument has separated in a vital or in a chronic abscess case? How far would you go in instrument retrieval?
Well, I suppose in the vital cases, it's hard to prove, but you're hoping there's less bacterial load. So in the necrotic cases, you'd imagine there'll be a lesion, or maybe on a cone beam CT you'll see a reaction. So there's more likelihood there's more bacteria. So in those cases, I certainly will attempt bypassing always more, and I spend more time on that case to make sure I gave it everything I could prior to then either going with removal or do we proceed with surgery or discuss other options. So, but certainly with the vital cases, I think you've got a better chance that it is less likely that tooth is fully infected as a biofilm that's fully established in the apical zone, and then you really need to spend more time agitating it. So I think it just depends, but with the necrotic cases, I certainly would really attempt at least bypassing.
On a similar note, are there any courses available for managing instrument separations?
Certainly. So I mentioned before, Dr. Yoshi Teruchi from Japan, he's the guru in removal of fractured files. If the dentist has a microscope and experience and has done courses, or for postgraduates, he's visiting Australia in March. I believe the Monday, which is the 4th, might have a few spots left. I believe unfortunately the Sunday's fully booked. So anyone interested, look up the ADA, New South Wales ADA CPD programs. It was advertised a number of months ago.
And Paul, if a patient is unable to tolerate a periapical film, for example, either a gag reflex or a small mouth, do you have any techniques or alternative methods for imaging?
Well, I think it's a very good question, and you could talk about this for quite some time. If it's a gag reflex, it's all about trying to keep the patient calm and distraction for me. I'm sure a lot of people have heard using the salt technique, putting a whole bunch of salt on the tongue. Essentially, it's distracting kind of that central nervous system about this gag reflex. Also, sedation is very good. I find patients on nitrous oxide or IV sedation for the severe ones. It's brilliant on what it can do for a severe gag reflex patient. They're sort of my go-to when it comes to trying to take periapical radiographs. I would never ever do endodontic treatment and not take periapical radiographs because of a gag reflex. That's probably the best thing to say. So you got to try and manage it, and you got to work with the patient.
And Mark, back to altered sensation. This dentist presumably has a patient who had some paresthesia occur to their patient. But it wasn't too bad. For example, similar sensation to sucking a lozenge that feels more pronounced during function, and it started a few days after a block was done. What sort of communication should be happening there?
Okay, so if it started a few days after the block, you've got to sort of think about why has it happened after that. So first off, is it related? Is there actually a relationship between the dental procedure a few days ago and this altered sensation? And let's assume for a second that this is related to it. You start to think, well, why is it happening a few days later? And it's likely going to happen a few days later due to an inflammatory reaction. Right, rather than it being that you have severed or cut the nerve, there's an inflammatory reaction around the side of the inferior alveolar nerve block that you've given, and that's compressing the nerve to a degree, which is why they're getting this altered sensation. So here's one where you would expect it to be mild and something that will resolve over time. That's what you're expecting. However, you can't just say that to the patient and say, all right, see you later, this should be mild, you'll be right. It is it is a few days afterwards. That's sort of that grey area of, well, do you hit them hard with the dexamethasone now? Are they having any other symptoms as well? Or do you just start with regular anti-inflammatories like your diclofenac or ibuprofen? So this is one because of the delayed nature of everything that I'd be having a chat to a MaxFax. Just call up your local MaxFax and say, this is the situation. This is exactly what happened to the patient and what they're experiencing now. And then I'd be having them followed up with the MaxFax and letting them dictate management from here. And you do expect a delayed response like this to sort of come back to normal.
All right. Chankrit, when you've cleaned and shaped root canals and you're confident it's been done properly and well, as I'm sure is always the case in your hands, when are you comfortable to obturate the canals?
Basically, no symptoms, no clinical signs. For example, there's negative to tender percussion. So basically, no symptom, no sign of diseases. And if canals are dry, ready to obturate. Yeah.
And when would you then review that patient after obturation?
Our review protocol is 6 months. Yeah, okay. 6 months, 1 year. We should be able to see some sign of radiographic healing.
All right. And Mehdi, do you think there's a difference in outcome for a root-filled tooth with a periodontal defect of 4 millimetres but no perforation versus a tooth with a periodontal defect of 4 millimetres that has had perforation repair done by an endodontist?
To be honest, if there's a 4 millimetre defect and the patient's able to keep it clean, I cannot see any difference between the two. I think that as long as this is a trick question, I think whoever's asking this, so long as they use a biocompatible material like a calcium silicate such as MTA, because you want normal repair periodontal ligament across that perforation defect. So for instance, the case I showed you with the 13-year review, I don't think that would look any different to the other side and the tooth on the left. Actually, there was minimal recession, similar pocketing depths on both sides after perforation repair. It was quite a large old perforation. As long as you disinfect well, you're able to remove the bacteria, you're able to put a biocompatible material, the normal ligament grows over top.
And Paul, what would you do if you think the patient might have a vertical root fracture in a tooth that had no prior endodontic treatment?
If you're confident that you've diagnosed a vertical root fracture, then that structural prognosis is hopeless. That's something that needs to come out.
And how would you diagnose that vertical root fracture?
Well, vertical root fractures and fractures in general need to be visualized. That's really the only way to actually diagnose them. But we can use a whole bunch of clinical examinations and radiographic examinations to give us clues on what could be happening. Like Mandy said, CBCTs will show some chimney defects, some halo defects. Then you can also look at them clinically. So if we're transilluminating and this vertical root fracture has actually extended up the entire coronal portion, then you can sometimes see it. So for me, visualize it. Also your periodontal pocketing. A lot of the times a 10 millimeter pocket can either mean one or two things. Is it fractured, or is that just the pathway for drainage via the periodontal ligament? So it's hard to give a perfect answer, but you just got to sort of collate all your information and say, well, I think this is most likely going to be a vertical root fracture.
And Mehdi, when it comes to perio probing, I know you quite like your plastic perio probes.
Yeah, so the thinner the probe, the better, because in that pristine looking gum where there's no other pockets anywhere, you might miss that narrow pocket that what might equate to at times a fracture or signs of a fracture.
Right, remember, if you're watching us on Facebook and you want to ask a comment, or ask a question or submit a comment, please, we're not monitoring the questions on Facebook, so head to the URL that's on your screen now and join the conversation there. Mark, how can someone go about specialising in endodontics in Australia?
So there's a lot of things that they can do. First off, after you graduate from dental school, do as much endo CPD as you can. Join your local branch of the ASC, come along to lectures, chat to people. I certainly spent some time visiting endodontists when I was in Melbourne as a freshly minted dentist and annoying them. That was great. So actually getting a feel for what a specialty is like, and that applies to every specialty. And then when it comes to applying for endodontics, there's a number of programs around Australia. We've got University of Melbourne. Bias here, all of us are graduates of the University of Melbourne, so that's right at the top. And then you've got University of Sydney's program, which has only been around for a year or two at this point.
Nearly a year.
Then you've got University of Queensland's program, University of Adelaide, University of WA, and there's another one. There's Griffith has a program as well. So, and then our friends across the ocean in Otago as well. So there's a lot of specialty programs to choose from in terms of your applications. And then just do as much endo as you can. Get your hands dirty, see if you love it. And if you think to yourself, when I wake up today and I'm going to work, I'm doing some endos, I feel good. I'm doing some extractions, I feel bad. Then try your luck, apply.
Can I add something more? Essentially, when you apply, you want to sort of stand out. One of the way for you to stand out is to perhaps get in touch with the head of the program, trying to offer your free labor as a research assistant, do some project, get some publication out. That's how you stand out.
Good to know. Now, Chankrit, sticking with you, if a tooth feels tender to percussion after root canal treatment, but the patient has no pain on chewing, has the treatment failed?
I wouldn't say so. If it's functional, because the goal of the treatment is not to make everything perfect. As long as there's no pain, as long as patient can chew on it, I think I'm happy with that.
See, I always use the analogy of a knee replacement or a shoulder replacement. They're not back to normal, but they're functional. And they consider that to be a ripping success.
Yeah.
And how would you then feel about putting an indirect restoration on a tooth that is perhaps still a bit tender to tapping, or at best feels different, but is comfortable to chew on?
Depends on a lot of factors. So if the patient, let's say the tooth has quite an extensive restoration, it's at a high risk of fracture, doing that crown is going to extend the tooth's lifespan. Whereas if you leave it the way it is, the situation could become much worse, much faster. Or if they're a bruxa, touching on the topic that Paul's talking about earlier, with an unrestored tooth with a vertical root fracture, the first thing I'm doing is looking at the patient's bite as well and trying to be proactive rather than reactive too. There's also the alternative of doing, say, a direct full coverage composite overlay or onlay for the patient, where it's not as nice looking or as well contoured as a crown would be, but it's still going to protect the tooth the same way and extend that lifespan. That's what it is. We're extending the lifespan of that tooth by as many years as humanly possible. And if it's functional, then we consider it to be.
I'll probably add one more thing to that, that sometimes the restoration, or the band for that matter, on that tooth might impede within the gingival periodontium area, and tenderness to percussion might be just
gingival related. We see that with orthobands all the time.
So I would always go for, okay, take it off, take the restoration that's defective or rough around the margins out, put in a direct overlay restoration first, flaticles or table. Often they would last anyway, and watch that tooth for a bit longer prior to then deciding on the definitive, more expensive restoration.
And Paul, how would you differentiate between a vertical root fracture and an endoperio lesion?
It's actually a great question. You get asked this so many times. Look, I think there's a lot of factors. When you consider perio-endo, you're sort of opening up a whole different topic here. You need to sort of assess the patient's periodontal status versus the endo. So in a patient that is a periodontally, affected patient, you're very likely that there might be periodontal issues with that tooth specifically. When it comes to a vertical root fracture, If I'm looking at a patient that has very healthy periodontium, and then that specific tooth has a periodontal defect, then I'm thinking that this is perhaps either endodontically related, whether it is the crack or whether it possibly could be drainage from that. Mark sort of said something really important about checking the occlusion here. So if this is a bruxing patient, a lot of the times we misuse the term vertical root fracture. A lot of the times it's a crack that's actually extended down to the apical tissues. So if you can visualize it, then you know. Ones that you are really unsure about, those are the ones where I'll most likely go in, medicate, and just monitor and see if we are going to get any resolution of our symptoms or our apical tissues. That will give you your answer. If you also go into a canal under a microscope, you can really see a bit more. So it's hard to give you a specific answer, but that's sort of my train of thought when it comes to these type of patients, and if I'm differentiating between those two kind of manifestations.
And I guess letting a patient know that we are trying our best here, but there are no guarantees for their troubled tooth. Yeah. So a bit of a comment on what we were talking about before about tenderness to percussion versus treatment failure or not. Are we using tooth survival as the determinant for success of endodontic treatment now? Mark?
It is a determinant, probably not the determinant. So you got to remember when we're talking about the success of endodontic treatment. Historically, endodontics it's had a pretty large bar to jump over, because when you look at the original outcome studies, if you did endodontic treatment and you had a large lesion that mostly healed but hadn't quite gotten there after 4 years, it was a failure. It was very cut and dry. Is there still a lesion? It's a failure. Even if you watch it over the next 20 years, it eventually healed. At 4 years, you throw it in the bin. It's a failure. So then from a biological point of view, we look at partial healing as being a success determinant. But what about in the situation where the lesion's unchanged, but the tooth's still functional? Because we need to look at what's the patient-centered outcome here. We have patients come in all the time saying to us, I don't know why I'm here. My dentist saw something on a film, but to me, if I never met them, might have been good. And that's fair enough. They might have been good for many, many years. So when we look at implants, a lot of the studies look at survival of implants. And when patients are comparing endodontics to implants, which is what we get almost every single day, well, if we're comparing apples to apples, we're going to compare survival. If we're comparing biological complications to biological complications, that's a different discussion.
All right. Chankrit, sometimes I wonder if I should be placing posts under rubber dam since the endodontist just completed the work. But placing posts under rubber dam is difficult. What would you recommend?
I don't think that is a bigger deal as long as you can keep the area clean. Perhaps if you worry about the saliva contamination, maybe after you prepare the post space and then you flood the canal with the sodium hypochlorite, I think that should be enough. You have to differentiate between presence of bacteria and infection. When you say infection, it means established bacteria. To get bacteria to establish, it takes time. If it's just exposed to saliva, I don't think it's going to turn into infection straight away. It has to be there for a long period of time. You need nutrients. You need a community of bacteria to get into it. So if it's just a superficial bacteria, you can just rinse out the area with sodium hypochlorite and it should be okay.
And Mehdi, why do endodontists tend to prefer non-zirconia crowns following root canal treatment?
So I guess this is a topic of mine where I'm just currently doing some research on, so I can give you guys quite a solid evidence. Hasn't been published as yet. Well, basically we talk about finite element analysis studies, and in the FEAR studies we've done, we have seen transfer of forces that we apply to the tooth. Its impact, as we know, is always around the cervical predominantly. And we've seen that transfer in much higher load in monolithic zirconia crowns compared to even IMAX crowns, that compared to gold, and the best actually proved to be composite restorations. So certainly I know everyone's placing zirconia, whether it's cheaper, whether it's easier to do, but I think watch this space because the clinical studies will come in future. Certainly the few study that we've done at Monash Uni and Sydney combined, we're seeing that effect, that the transfer load from a hard object to the root is certainly much, much higher.
And Paul, is it possible to get a vertical root fracture in a tooth that does not have a history of endo treatment?
You certainly can. Doesn't happen as often, but there's definitely cases that we see. There's also publications about it, just not as common as those with a history of root canal treatment.
And Chad, at what point do you give up looking for the MB2 canal?
Never give up.
But still try not to perforate.
Yeah, definitely. I think CBCT helps a lot because before CBCT, it just basically you have to keep going, but whether or not it's there or not, we don't know. But with the CBCT right now, I think you know before you get in whether you need to find MB2, because if the canal is in the center of the root on the axial view, you know that it's just only one canal. But if the canal is in ovoid shape and you have one dot toward one end, you know definitely that there will be another one on the other end. So you have to.
We still have a few questions to get to, but if you have to leave us now, you can click the feedback link on the viewing page to organise your CPD certificate. You'll also find the referral page for Gentle Endodontics at the bottom of your viewing page as well. Paul, for upper anterior teeth with straight canals, do you tend to use rotary instruments all the time? Would you ever just use hand files?
I have been taught using rotary instruments. Now, my hand files do have their place in my instrumentation protocol, and that's more so in the early stages. So that's more so establishing a glide path. We have rotary instruments that, can go up to significant sizes. So there's probably not a case where I'd ever need to use a hand instrument in order to prepare the canal, unless I'm trying to establish a glide path or trying to get around a ledge or bypass an instrument. That's probably when I'd use my hand instruments in those situations.
All right. And Paul, sticking with you, given presumably you've been an associate at some point a little more recently than some of our other panellists, as an associate with an interest in endodontics, do you have any tips on how to convince the principal dentist to get presumably a CBCT scan set up, especially if they don't do much endo?
Well, it's quite tough. It's like me trying to ask you for something. I think you got to sort of plead your case in sort of saying that the patient is at the forefront of this. How are we going to try and improve the care to our patients? And this CBCT is going to give us more information in order to actually establish that. Once you sort of have that kind of method or that kind of philosophy going, then you can sort of branch out into say, well, if our patients are going to get better care, we're going to be able to sort of get that word of mouth out there that we do really high quality treatment. We're going to sort of increase that kind of production in terms of endodontic treatment, and you might be able to persuade the principal dentist that way. That's how I would target it.
Okay. And Mehdi, you've given us some ideas about different restorative options. This question is, what is the best restorative option post-endodontic treatment? I guess that's a difficult thing to answer because there are different ways to assess what the best is. There's the survival of the root canal treated tooth. There's also survival of the restoration.
Yeah, so no, it's a multifaceted question because are we talking anterior teeth? Are we talking posterior teeth? But as a general rule, what I aim for in the posterior dentition, where I think the coronal restoration is more important than anterior. I think in the anterior, unless it's a cosmetic issue, most often even a direct restoration like a mesioincisor or an axis and one part of the wall missing is probably enough, unless you decide to crown the tooth. In fact, I don't recommend crowning laterals unless you really have to, because many catastrophic failures occur when you have to crown them because they thin around the margin, and then most often you'll have to place posts in them to strengthen them after the endodontic therapy. So with that said, in posterior dentition, depends on the case, depends on whether the tooth is compromised or not. But with compromised teeth, if we're talking compromised teeth, I do like a full bracing crown with a fine gold margin. So either gold on the lingual with porcelain or fine gold margin, because I also know that Terry Walton studies are 30-40 year review studies, and many of the prosthodontists in Sydney get trained to do that and around Australia because they last. They last in, and you can actually obtain ferrule by going deeper within into the periodontium, and you can even place restorations that are very fine with no overhanging margins, almost like having implant crowns that are subgingival and having fine gold margins, I think, really helps protect that tooth better against fracture. Flat occlusal table as well. I really can't stress that enough. Flat occlusal table, watch the bite. It is, at the end of the day, survival of that tooth. It's not just us, it's what you do. And I think the dentition and the bite plays an important role. So pick up those signs of bruxism early, apnea, what have you, early.
And the flat occlusal table is to minimise lateral forces on the tooth?
That's right.
Okay. Mark, what would you prefer, an overfilled or extruded sealer in a normal tooth or an underfilled root canal?
Neither.
Can I pick option 3?
What is option 3?
Option 3 is neither. Just, get to length and fill it up, nice and thick up to there. But they both have positives and they both have negatives. So a overfilled root canal treatment that's been disinfected to a satisfactory level, it's just, a little bit has come out the apex, little sealer puff, a little bit of the GP is out. That is not going to lead to as many complications as being 5 or 6 millimeters short of the working length, because they're leaving a significant amount of bacteria behind. It comes more down to, well, which area of the mouth is this tooth in? An extruded bit of sealer in a lower 7, 4, 5, 6 is probably going to be more detrimental to a patient than in a maxillary central, for example. So it comes down to that context. I guess the principle is to aim not to do either, but we still need to get to length to do satisfactory endo. So you don't want to be ending short for all your cases just because you're scared that you might get a bit of a sealer puff. Sealer puffs in general have no impact on outcome. It can delay the healing somewhat, but if you watch them long enough, they heal just as readily as any other endo case.
I think the issue here is about disinfection. It's about bacteria. It's not about the length of the filling, and the GP in and of itself, it doesn't do anything. It's inert material. The studies Jogren 1995 show that very clearly. If you embed a GP in the bone of the rabbits, you don't create any inflammation or anything. It's an inert material. So the issue here is, can you clean it? If you clean it enough, then it doesn't really matter.
And Mark, going back to what we were talking about before, if a patient has a short obturation with no periapical radiolucency, presumably on a two-dimensional film, the root canal treatment was completed 20 years ago and the tooth is asymptomatic, the general dentist wants to place a crown, does the patient need retreatment or potentially specialist assessment?
So this is a great question, because we get these sorts of cases every week, all right? And there's no literature to support what happens here. So it's a combination of anecdote, experience, and I guess you could say logic being thrown in there. So the big question that I get a lot of the time when I get these patients that come in is, why are we doing a crown in the first place? The tooth has been perfectly functional for those 20 years. What is the driving cause of a new crown? Is it a leaky restoration? Is it a leaky crown? If it's a leaky restoration or old crown, what are the odds that that's contaminated the root canal system? If it's a short endo, there's less resistance to those bugs getting to the apex, and possibly, whilst there is no apical lesion noted on the film, doesn't mean that there's no contamination of the root canal system. Factor that into what we mentioned about CBCTs. Radiographically in 2 dimensions, it looks good. In 3 dimensions, there might actually be an apical lesion, or, as we see a lot, there might be a completely missed root canal. And at the end of the day, I use the analogy with patients. If I've got a CT and there's a missed root canal in this old endo and the dentist wants to put the crown on it, I say, well, you've got an old bathroom and it was done 20 years ago, and the toilet flushes and the showers and the water seems to go down the pipes. Are you going to go ahead and renovate that bathroom if it turns out that one of the pipes is just going down into the ground and isn't actually connected to the rest of the system? And you're probably not going to do that. You're going to redo the plumbing to redo that bathroom. And patients seem to get that from the analogy point. They understand houses better than they understand teeth. And they go, yeah, I probably should redo the plumbing in that situation. Or if they don't, they take the chance that it is about patient choice as well. If you place a crown here, there is a chance it flares up, and I'm going to have to cut a hole through that beautifully made crown in order to reaccess everything. And it's normally easier to do that before you've put the tiles down on the bathroom floor.
I think that's an excellent analogy. Checker, what's your opinion on treating teeth that have cracks in them? We've had some questions about this. What's your philosophy on chasing cracks?
I think that we don't have the good answer. Basically, I think there's a pros and cons. Chasing cracks, it's mean that you remove the cracks, but at the same time, you remove the cracks, you might actually weaken the tooth further. So there's no winning side here. You can leave it there or you can chase it. But to me, probably I wouldn't chase it. This is my personal opinion.
Does anyone else on the panel have a different opinion?
No, I agree.
I don't believe in chasing cracks. I believe in bracing cracks.
Yeah.
If you see them, the best you could do is basically brace them, and sometimes just watching cracks, like those cases what I call deposit cases, where you might medicate, band, watch and see, because sometimes you cannot see everything. No point in chasing, you still won't be able to go subcrestal. I mean, if you can't see it, you medicate it. If you think it's not deep, you brace it and you watch it, and if there's no deep pocket, then you go the next step and you place a direct restoration and you watch it longer, and then you place the indirect restoration. So you take your time with those cases.
Chankrit, is it necessary to instrument teeth that have large canals? Could we conceivably just irrigate?
Interesting questions. Again, don't have a good answer, because in theory, you don't really need to scrape the whole root canal wall to get the good outcome, as long as the irrigant can go down and it will work, as in it can kill bacteria. So even if you look at the micro CT studies, there's a lot of area, a lot of root canal wall that hasn't been touched by the phi, and it seemed to be working quite well.
Well, in anterior teeth, open apexes, we're not scraping the walls. The walls are thin enough as it is, right? So we're using our adjunctive irrigation protocols. We're using ultrasonics. We're using sonic activation as well, for example. Like, we're doing all these adjuncts to strip as much bugs out from the root canal system as possible. But, how large is large? Is this a large palatal of an upper six, or is this like an open apex? Because we're only using a file to confirm our length with an open apex case. We're certainly not scraping the walls with it.
All right, Mehdi, there's a lot of questions about zirconia and restorations. You mentioned zirconia crowns may cause more root fracture or more tooth fracture. Is this the same for anterior teeth?
Depends on the bite. So in anterior teeth, I guess the bite might be more favourable towards zirconia crowns, unless there's an edge-to-edge bite or we're dealing with a bruxa sleep apnea patient. Remember that even with those sort of cases, even if, like, say, the tooth survives longer, remember the poor lower incisors and how they wear, because monolithic zirconia crowns on such teeth, the lower incisors can also wear during excursive movements as well. So again, I personally think there are better materials. I understand why dentists do place zirconia crowns, but I feel that with time, the literature will 100% come out, coming from an endodontist perspective, coming from someone who's doing research, current research on it.
All right, we are running tight for time. Paul, could you refresh our memory on how far down the canal we should be placing our irrigation needle?
Well, it's a great question, but how do I answer this without getting in trouble?
You won't get in trouble.
Look, so you want the irrigant to theoretically get down to the apex. When you look at the literature, it depends on what type of needle tip you're using. It also depends on how much force you're placing on it. Obviously, the more force, the further this is going to go down. But you don't want to exceed the pressure from the apical tissues that you're going to extrude. So be sensible with that. I like to use side venting needles. The literature shows that side venting needles can only increase by about 1 millimeter beyond the needle, and open-ended needle can get to about 3 millimeters. I don't like using open-ended needles because you have higher risk of certain hypochlorite incidents. So I use a side venting needle. Get down to a comfortable position where you're not binding your needle. Also, you're not going out the apex, but also if you have the ability to use activators or anything to, further facilitate the irrigant down into the apical tissues rather than pushing this needle tip further, that's how I would sort of think about the irrigation protocol. But always err to the side of caution rather than being a bit too aggressive with it.
Mark, you mentioned teeth that are immature teeth. So if we're looking at a tooth that has an open apex, how do you go about achieving an optimal or best possible apical seal?
Yeah, so there's two ways of looking at it. The first is that you might not even need to do full-blown root canal treatment in the first place. You might be able to do a regenerative endodontic procedure, also known as a revasc, where you try to stimulate some sort of hard tissue deposition to thicken the root canal system up. Now, whether it actually thickens the root itself or something else is another thing entirely. But if you're going to do, say, an apexification or a conventional root canal treatment, you really need to be using something like MTA or biodentine as an apical plug, and then you put thermoplastic gutta perca over the top of that, and then you restore it as normal. But that can be incredibly complicated, and if you don't have a microscope, and you don't have a lot of experience dealing with these are cases that can cause us a lot of headaches, and it's probably best that you send it to your local endodontist to let them stress about it.
That sounds like good advice. Mehdi, finally, does the use of an endodontic activator for irrigants increase the risk of hypochlorite accidents? And which activation system do you use?
You got to obviously have logic. So if we're talking open apex, you've had a look at the CBCT and it looks quite wide, then I do still agitate, but I may in those sort of situations agitate a lot more lightly. I might make sure I adjust whatever tool I'm using, whether it's I personally use the eddy. I like the eddy tip because I feel it's got enough acoustic streaming effect. I used to use the endo activator. I didn't think it did much, and I think Muna in the room in the back should have answered this question probably better than me. But I would then make sure I got my length right, and make sure I cut that endo activator tip and eddy tip 2-3 mils short if there's an open apex, and then I agitate just to make sure. Do we getting some streaming effect? I still prefer that because there's isthmuses. No canal is round, it's oval, there's isthmuses, and I want to make sure I've cleaned it as best as I can. The other point I want to make is I will be switching to lasers because I believe that lasers are more gentle at cleaning those areas. They do cause the streaming effect, but maybe we can revise what we do with hypochlorite in those situations if we've got lasers as well. So lasers are watch this space.
Very interested to watch you in that space, Mehdi. Look, we've come to the end of our time together this evening. If we didn't get to your question, I apologise. We'll just need to consider episodes 2, 3, 4 and 5 of Gentle Endodontics TV. Thank you to all our experts for sharing how endodontic complications can be avoided, minimised and damaged. Thanks for being here.
Thank you for having us. Thank you.
And thank you for watching. If you're watching us live, you can claim a CPD certificate for this event by clicking on the feedback link on your viewing page. And if you're needing assistance with a patient case, you'll find the Gentle Endodontics referral form at the bottom of your viewing page, or you can use the electronic referral facility on the Gentle Endodontics website. Alternatively, you can always contact Gentle Endodontics via the details that have just appeared on your screen, and we'll be back. Those details will appear again shortly. Enjoy your evening, and thanks for joining us on Gentle Endodontics TV.